Good evening to everyone who is joining us for our 7 Starling webinar series designed to give you, healthcare providers across specialties, pearls to help you feel confident in supporting your patients with perinatal mood and anxiety disorders. My name is Nazanin Homaifar, and I'm a practicing OB-GYN in Northern Virginia and the medical director at 7 Starling. 7 Starling is a maternal mental health clinic that treats women experiencing anxiety, depression, and trauma throughout fertility challenges, pregnancy, pregnancy loss and miscarriage, abortion, postpartum, and early parenthood. We are thrilled. I don't know if I got to tell you, Dr. Clark, we are thrilled to announce that we now accept Anthem and Cigna Evernorth insurance across Maryland, DC, and Virginia. And starting later this month, we will be in network with Care First Blue Cross Blue Shield.
Excellent.
Yeah, increasing access for our patients. You will be the first to know as we bring on more major payers throughout the year. And the highlight of my day is that I get to be joined by Dr. Crystal Clark. She is an associate professor of psychiatry and behavioral health sciences and in obstetrics and gynecology at Northwestern Feinberg School of Medicine. She has dedicated her career to reproductive psychiatry and the advancement of maternal mental health as a researcher, educator, clinician, and thought leader, and also an advisor to 7 Starling. Welcome, Dr. Clark.
Thank you for having me. As always, I love our discussions. So I look forward to this one today.
Absolutely. And you were recently in London at the Marseille International Conference. I think I lost track of how many presentations you gave, but how was it?
It was great. I gave 3 and I was kicking myself the whole time. Like, why did I agree to do that? So but
Yeah.
it was a wonderful time to be there, historical time, a lot of, clearly a lot of energy, some definitely mourning for the Queen, but a lot of people coming into town
Yeah.
to pay their respects, but also to, get together. And so it was, it was a great time. And lots of good information shared about the latest in maternal mental health.
What were your presentations on?
So my presentations were, we had a few different topics we covered. One was one of my areas of expertise, that being management of or psychotropics or pharmacology agents for bipolar disorder and pregnancy. So I was talking about lithium and quetiapine specifically, and how the pharmacokinetics change and how we should consider that in dosing and management of those medications. But I also did a diversity, equity, and inclusion presentation as it relates to maternal mental health. Did a symposium with several of my colleagues, which was well received, and then another one on advocacy and how we're changing the landscape of perinatal mental health through, platforms like 7 Starling. So
Yeah, amazing. Was there anything, was there a particular talk that left you more inspired or excited?
Yeah, honestly, the DEI talk left me very inspired, and there were so many talks, but and not necessarily my part in the DEI talk. My colleagues who just delivered some exceptional presentations, really forcing us to think more broadly and more, I think, uniquely about how we're approaching perinatal mental health for everyone. So those were very inspiring, and that's been the theme of Marseille International and Marseille of North America right now. So we're seeing a lot more discussion about these topics.
I think that actually couldn't have been a better segue to our topic today because it's so relevant what we're talking about and how we can improve our ability to screen and needing so much more context for that. So today our talk is going to be about the history and utility of our screening tools for perinatal mood and anxiety disorders and which combination we may consider using, because as we know, everyone, there's various combinations that people like to use. So I'd love to dive in.
Yes, let's do it.
I'd like to start with the 3. I'm familiar with 3 major screening tools for perinatal mood and anxiety disorders: the Edinburgh Postpartum Depression Scale, or EPDS, the
Mhm.
Patient Health Questionnaire-9, so PHQ-9, and the Generalized Anxiety Disorder-7, so the GAD-7 scale. Can you
Yeah.
tell us a little bit about each screen and their role in the clinical setting?
Absolutely. So all screens, all three of the ones that you named, I love to use myself. The PHQ-9 and the EPDS, depending on who you're talking to, someone will say, "Oh no, I like the PHQ-9 better than the EPDS," and the reality is, as it relates to their utility in the clinic, studies, many studies have shown that they're very almost equivalent in how they score in terms of sensitivity and specificity for identifying depression. So when we compare it to standardized diagnostic scales, they come out about the same. So really you can use either one to screen for depression. They're not meant to be diagnostic tools, they are screening tools, but you will find in clinics that people kind of use them as a diagnostic tool. It's like, okay, she was positive on that screen, so we're going to start that antidepressant. I encourage people to make sure they understand that the patient actually has the diagnosis because, as we'll talk, I think, a little bit more about later, interpretation of the screen by the patient can definitely skew those results. So it is good to have the conversation to make sure the diagnosis is correct. But it does both scales do a great job of typically identifying those who have depression or are at high risk for depression. The GAD-7 is an anxiety screen, which again, very short, similar to the EPDS and the PHQ-9, can be completed in 3 to 5 minutes by the patient. As a self-report, they're all self-reports. And the GAD-7 actually identifies 4 different anxiety disorders. So again, someone scores positive on it, it doesn't tell you which anxiety disorder they have, but it will let you know that they definitely do or don't have anxiety. So the 4 that we're thinking about is, panic disorder, generalized anxiety disorder, and it can be panic disorder with or without agoraphobia being 2 of the anxiety disorders. And I'm blanking on the 4th, to be honest. It's PTSD, sorry, post-traumatic stress disorder, but it does not identify OCD, for example.
I had one, I've been calling it GAD-7, and clearly that's not correct.
It stands for generalized anxiety disorder.
Yes.
And it's a
But what, but
seven questions. Yeah.
how do you pronounce the abbreviation?
Yeah, GAD or G. I just say GAD, but
Okay.
some people call it GAD. It's okay.
It's like in obstetrics when people call a rupture of membranes various things, and you hear it from
Yeah,
and you're like, that's not how I said it.
right.
But I didn't realize that it was actually screening for different anxiety disorders. So
Yeah.
do you have to be well versed in, like, can only a psychiatrist or psychologist tease out the difference in the score? Or how do you do that?
Yeah, no, great question. So yeah, it's not going to tell you based on the scoring which anxiety disorder you're is being reflected by the patient's answers. For everyday clinical purposes, especially in an OB/GYN's office, for instance, or a internal medicine or family medicine doc's office, I say just determine whether or not they have anxiety, because in most cases it'll be treated the same way if you're going to start a medication. And in terms of therapy, that will be the therapist's responsibility to tease out, okay, well, where does this anxiety fall and what types of therapy do we need to do to help. But yeah, the scoring, it doesn't really tell you much about what type of anxiety you're dealing with. It's really about the constellation of symptoms and how they present, which again requires a little more digging to really tease out, okay, where does this fall? But also anxiety disorders can be comorbid. So, there could be a lot of overlap, which also requires some teasing out to distinguish.
That's helpful context because I was just actually seeing a patient on Tuesday who's 3 years postpartum, but was
Mhm.
talking about how much she worries about her child. I and I knew there must be something underlying. So I said, let's fill out the survey together. And
Mhm.
I think next time I will tell her rather than I said this screen's for anxiety disorder, but I think it's really helpful to provide people more of a context that this screen can tell you about anxiety, it can tell you about panic disorder, PTSD. So
Yeah.
it opens up the playing field that you're not just putting someone in the category
Yeah.
um, of anxiety. So thank you so much for that.
Yeah.
In terms of these screens, what are some of the benefits and limitations of them?
Yeah, so the benefits are that you can identify a person that is at risk for depression. And when I say at risk, again, I'm using the language that we use as psychiatrists because we, again, think of this self-report as a screen and not a diagnostic tool. So someone who screens positive is at what we would call at risk for having depression or another mood disorder. Could be something else as well. But it's so important, I think, easy for patients to come in and say, oh, no, I'm okay, and dismiss what they're feeling or not even have the language to really describe what they're feeling. So when I take these questionnaires, and it's like, oh, wow, yeah, my sleep has changed. Although sometimes they'll rationalize that depending on where they are in pregnancy or postpartum. And, oh, yeah, my eating has changed. Oh, yeah, I have been more irritable and just not appreciating that these are even things they've been dealing with. But so it can be eye opening and education for the patients as well. So it's so important to give that screen because you can ask, well, how are you doing? And most people are like, oh, yeah, I'm good. Just dealing with whatever it is, just getting bigger or just having sleepless nights because I have a newborn. So we want to get past the small talk and really get down to, are you experiencing any of these symptoms? And even if they're only experiencing a few and they don't have a positive screen, it might be an indicator that this is someone to watch, because this could be the indication that something's brewing and has the potential to get worse. So the limits, though, of the screen are that it's language, really. In some ways, even though the EPDS is translated in so many languages, at the end of the day, even people speaking the same language but from different backgrounds, the language, just the English language might mean something different to that person and that it might not resonate with them. So, one of my concerns for a while has been, in the US, does the EPDS really use language that is resonating with a Black woman or Hispanic woman or Indian woman? Is it sensitive enough? And what I have found in my practice is that sometimes I'm talking to a patient and I can have both extremes. I have them fill out the assessment after we've had a discussion, and they've said they feel great, and then they fill out the questionnaire and they feel terrible. But I've also had the reverse where they fill out the questionnaire and they're pan positive, and then we discuss, and it's like, oh no, these were scenarios or situations that were
Mhm.
appropriate in the moment for what they are circling. Like they were really irritable because their sister broke a valuable lamp. It's like, okay, well, yeah, it's like this is
Yeah.
not a mood change. um
Like
so
asking
really,
someone to do a review of systems, and you're like,
yeah.
not in the past 5 years,
Right.
in the past.
Exactly. So being able to be like, okay, no, this is what I'm talking about. But also, I've learned that people might describe sadness different. They might describe it as feeling heavy, or it's a certain type of stress that they describe it as, or just different language again that they
Mhm.
use that otherwise would lead them to rate a EPDS or PHQ assessment negative. They're like, oh yeah, no, I'm not sad. I'm stressed. I'm
Mhm.
not, I'm not lacking interest. I'm just tired. It's just like, um,
Right.
so it's really, those are the limitations. I think the context and the cultural language, really.
Yeah, because when you look at EPDS, I remember
Mhm.
this question always strikes me as a little bit
Mhm.
odd. Things have been getting on top of me.
Yes, yes.
Right. Yes, most of
Mhm.
the time I haven't been able to cope. Yes, sometimes I haven't been coping as well. No, most of the time I've coped well. Like it's a very it,
Yeah,
it's a hard question. It could be a hard question to interpret.
exactly.
Do you have any of the same limitations for PHQ-9 or um,
Yeah, I think they both are similar. I definitely think the EPDS might have a few more, again, despite the many ways it's been validated, and and adapted to other languages. PHQ-9 similarly, I think maybe less so than the EPDS, but definitely
mhm.
has some of similar language that we use in DSM 5 at this point, and every patient doesn't resonate with that language. Same with the GAD-7, and so
Yeah.
that is why it's so important to take that extra 3 to 5 minutes, which I know are just very hard in our current medical practices, to make sure the patient understands what they answered,
Right.
and how they articulate it resonates with the intention of the screen.
Can you remind us? I know we've talked about this in previous webinars, but what the cutoffs are to diagnose a PMAD with each of these?
Yeah, so I'll start with the EPDS because historically the EPDS, it's been like, okay, anything above a score of, well, 13 or above is, considered highly likely to have major depressive disorder. And and over the years, it's like, okay, but what about these people who are scoring 11? What about a 12? What about a 10? A lot of those people have depression as well. So there was some thinking some years ago that it should be broken down into, thresholds. So 0 to 6 being less likely to have a depression, but a score of 7 to 13, I consider minimally depressed. And then, above a 13 being moderately to severe depression. So similarly, you have the PHQ-9, and the PHQ-9 does it a little bit differently in terms of the thresholds. And I want to reorient everyone. So the PHQ-9 is it's a 9-item questionnaire. The questions really, the answers go from 0 to 3. It's based on the frequency of symptoms over the past 2 weeks. So, how often have you felt, irritable or sadness,
Mhm.
etc. And so a score of 0 to 4 is considered minimally depressed with that screen, or 5 to 9 is considered, actually, I think, and forgive me, I have to just double check this because I want to make sure I get it right for everybody. It can be a little hard to remember all the cups, but yeah, 0 to 4 actually is normal. Just want to make sure I was saying that right for the PHQ-9, and then 5 to 9 is considered minimally depressed, and then 9 to 14 being moderately, and then above that is being severe. So the PHQ-9 does it a little bit differently in the sense that there's no like, really 0 to 4 is the only range in which you are considered normal, but anything above that, there's some degree of depression that the patient is likely to be experiencing. And you have a similar rating scale and threshold cutoffs for GAD-7 as the PHQ-9. So they're actually identical in terms of that rating.
Okay. Yeah, because when I remember going through the GAD-7, it was
Mhm.
I could say, oh, it looks like you might have some mild anxiety or
Right,
mild
right.
depression. So,
Yeah. So
okay,
it's a little clearer than the EPDS, where we've just established these thresholds kind of after the initial criterion was set when it was first developed.
got it. And do you think, I mean, do you think there should be other screens that we consider when it comes to perinatal mood and anxiety disorders?
So as a bipolar expert, absolutely. And there's two. I'm definitely biased on the bipolar screen, maybe because I treat so many of these patients, and it's such a high risk, a highly vulnerable time for people who have bipolar disorder to have an onset or a recurrence of mental illness during this perinatal period. So I think it's so important that we identify them and distinguish bipolar depression from unipolar depression, which is, it's easy to, not appreciate the difference, because many times a patient with bipolar disorder comes in depressed, it looks just like any other depression. So so with that said, the mood disorder questionnaire, otherwise known as the MDQ, I think it's one of the best we have out there right now in terms of a quick self-report screen that can give you a sense of, is this patient, again, at risk? This is definitely even less diagnostic than our EPDS or PHQ-9 or GAD-7, but it does let you know enough to say, okay, should I start that antidepressant, or should I actually try to get this person in with a psychiatrist to do some further diagnostic assessment before I give them a medication that could actually make them worse.
And so, and yeah, that would you only offer that to someone if you were worried that they had? Or how would you incorporate it, for example, if you were doing a PDS?
I mean, ideally, it would be, in the ideal world, it would be offered right along with the depression screen, whether you're using the EPDS or the PHQ-9 and the GAD-7. But if that's not feasible, then I would say if a person scores positive on an EPDS or a PHQ-9, I will give them an MDQ first before starting a medication.
Oh, wow.
Yeah.
That's like the emoji where the brain is floating.
Yes.
I never even thought. Okay. So I'm just going to highlight that again. So if you have a patient that is screening positive for depression with EPDS or PHQ-9, then you should consider doing the MDQ bipolar screen next to make sure you're not missing an underlying diagnosis.
Yeah.
Bipolar. Okay.
Now we'll give the caveat that the MDQ screen, it can, yield its share of false positives. So, so it's not a perfect screen, but given that we have had patients be placed on an antidepressant who actually had bipolar disorder and actually committed suicide because they went into a mixed state or some other manic episode or something, we want to be careful, and even though that's a small risk, losing anyone's life it's not what we want to do.
Absolutely. And I think that's why making us all more knowledgeable so that we can feel like we can lean into this rather than want to step away and not address it at all is so important. How do you think we should be implementing these screens in the ideal world? Would you screen a patient with a history of a mood disorder differently? I mean, ACOG says, I think I went back to their bulletin. They said everyone should be screened at least once in the postpartum period, and then if they are at risk during pregnancy.
Yeah, so we have so much great data out there from different investigators who've been studying postpartum depression and its onset. And so what we've learned from those investigators is that postpartum depression and postpartum anxiety, postpartum recurrences of bipolar disorder actually often are onset earlier in pregnancy, with there being subpopulations onsetting first trimester, second trimester, and third trimester. And we've seen different characteristics of these different groups. But with that said, having onset during pregnancy really, I think, encourages us, or should encourage us, to screen at least once each trimester, because we're seeing a lot of that happen well before they get to postpartum, and maybe we can intervene and prevent further worsening by the time they're postpartum.
Absolutely. And I'm seeing some questions, and we will get to those at the end. I think the only thing is, like, logistically, this is something you and I have spoken about. I've talked about this with Adrienne Griffin a lot too. It's just logistically getting providers to screen more consistently is really hard.
I for Adrienne, I needed her to help us with finding a way to push policies back where doctors have more time. It's just ridiculous, the time erosion. And so I definitely empathize with, just well, where we're going to fit this into this clinical day or this clinical visit.
Mhm.
I don't know if if we screens, kind of like your paperwork when you come in, that's often how I do it. Even as someone who does this, this is my main focus, but I have them complete assessments, when they come in to check in for their appointment. Of course, now you got to assume they arrive on time and all of those things. I've even had patients in this new age of telemedicine, complete things within 24 hours before arriving. So that helps to cut down time and allows us to kind of review that right at the beginning of the appointment.
And that was going to be one of my other questions is that is there any preference as to how the patient answers the question? Is there anything like if one were to go through it and have them answer versus them completing it on their own time? Do we see variation in responses?
I absolutely think we do, although I don't know that there's been any great studies about this. Anecdotally, absolutely. I'll have patients give further clarification on what they're saying, and that might, make me feel like their symptom is more severe or less severe, depending on their response. But I think for the sake of time and those who are not, this is not their, psychiatry is not their main profession. Um, I'd say give them the self-report, let them fill it out. And if there's any, if it's positive or pan positive, it's worth saying, okay, I noticed this. Getting, again, if you can spend that extra 3 minutes just to make sure that you're understanding what is meant by these pan positives, and not necessarily going one by one, but pulling out a couple, and saying, "Hey, I realize you're feeling pretty bad based on what you answered here. Tell me a little bit more about that." It could just be an open question like that, and see what they say.
That's great. And I love that tip of just pulling out one or two of the questions too,
Yeah.
not feeling like you have to go through all of them.
Yeah.
I think, and really quickly, do you ever use a combination of these surveys? So, with the limitation of EPDS not really screening for anxiety, should
Yeah.
everyone be getting both GAD-7 and either PHQ-9 or EPDS?
I absolutely, because they often go so hand in hand, the depression and anxiety symptoms. And so, and we know that anxiety onsets just as often in pregnancy and postpartum as depression. So it's so important, I think, to look for both. You're going to treat them the same way, but um, you want to be able to follow along and make sure those symptoms are being addressed, and if there's a need for additional support, like from a therapist or a social worker who can do some focused anxiety therapy, for instance.
That's, I think that's a great idea. And you might start hearing the knocking at my door. My little girls are outside the door knocking, which
I love
means
it.
that we're going to wrap up. And we have one question from the audience. If a pregnant patient screened positive with, I'm so sorry for the noise, with MDQ, would you recommend involvement with psychiatrist ASAP instead of management with therapist and prenatal provider?
Yes, I would say ASAP, like get them in as soon as possible. Because those with bipolar disorder are at risk for postpartum psychosis. We don't have good indicators of like, okay, when might this turn into, some more severe episode? Might they flip back to mania or a mixed state, or they're higher risk for suicide. So I will get them in as soon as possible so you can get them on the right treatment as soon as possible. And I will say, um, a lot of people, psychiatrists and psychologists, have a hard time diagnosing this, even more so amongst some of my psychology folks. So that's because that's not I think, the main population they're treating. So another reason to get them to a psychiatrist, in hopes that that person is comfortable with bipolar disorder.
Makes sense. Well, Dr. Clark, thank you so much for all this information today. As always, you've left us with many new points to ponder and reflect on, and I love being able to like immediately use them the next time I'm in clinic. So thank you.
Yes. Well, keep me posted how it works out.
Absolutely.
I'm always learning from my colleagues, especially my obstetrician and gynecologist on, you know, that feedback on how we can continue to think creatively about, well, how do we make this work in the system that we're dealing with.
Yeah, I agree. I mean, this is why it's so these talks are always a highlight for me. And the providers who joined us today, we hope you found these 30 minutes engaging, notwithstanding the knocking of my children at the door, and very informative. At Seven Starling, we are committed to providing the full spectrum of women's mental health care and would love to support you and your patients. Please check out our website, sevenstarling.com, to learn more about how we may help you in your own practice. And if you liked this webinar, please subscribe to our newsletter so we can keep you informed about future events. I hope everyone has a great night. Thanks so much, Dr. Clark. Take
All
care.
right. Thank you. All right. Have a great evening.
You
Bye.
too. Bye.